Hello everyone and welcome to this edition of Dr. Krob's Headache Vlog. I'm Dr. Alexander Krob, headache expert, and this is one of a series of videos on headache pattern recognition. These videos are really designed for healthcare providers, including primary care physicians, nurse practitioners, physician assistants, medical students, residents, nurses, and researchers to focus their skills on pattern recognition so that they can help people who are living with headache diagnosis have a more accurate, more effective diagnosis. Of course, if you are a person living with a headache diagnosis, a so-called headache patient, you are welcome to follow along. I think that you will gain from this an increased understanding of your condition from the viewpoint of a healthcare provider, and that will help bridge the gap between you and your provider, improve the quality of communication and quality overall, and I think you will see better outcomes in terms of improved control over your headache diagnosis. The format of this series of videos is that I will be introducing a typical headache diagnosis through the experience of an idealized patient, sort of formulated from a sampling of the patients that we typically see in the headache clinic. And we'll use that patient's experience to help providers not only know the official diagnostic criteria according to the International Classification of Headache Disorders, but also recognize some patterns that can be much more easily and beneficially employed in a clinical setting to help people in their clinic. So, with that said, let's start with the case of Emily. And Emily is a 29-year-old mother of two who's a teacher at a local private school. She reports recurrent headaches over the past few years since starting a stressful job. Her headaches happen 2 times a month on average, and each lasts most of the day and sometimes even bridges 2 consecutive days. The headaches tend to start without warning on one side of her head and usually gradually worsen to become severe throbbing pain that's just all over. When they get that bad, she says, fluorescent lights and playground noise just drive me crazy. She says, when they're really bad, I get sick to my stomach, but I usually don't vomit. So, over the past year, she's been treating these headaches with 3 or 4 Motrin, which usually works, but she misses a day of work every 1 to 2 months because of her headaches. And her employer is starting to become concerned about her frequent absences, so that's why she's here. She needs some help. This is medical notation for her history and physical exam. And her medical, family, and social history is notable for the fact that she's had a tubal ligation. Her review of symptoms, which is a list of a constellation of symptoms that patients usually receive when they present to the office for a visit, is positive for fatigue, poor sleep, and intolerance of cold. She has no known drug allergies. She's not really on any prescriptions. Her vital signs are overall unremarkable. Like me, she's overweight but not obese. Her general examination is notable for some wear and tear on her teeth and tenderness of her neck and shoulder muscles, which is often seen in people who have an active headache diagnosis. And this comes from head splinting and jaw clenching. Otherwise, her general examination is normal. Her neurologic examination shows a Hoffman sign in her left hand. And this is really mentioned here to highlight the idea that humans are imperfect, and our imperfections make us who we are, and not every imperfection is an abnormality. And in the case of an isolated Hoffman sign, this is simply an imperfection. It has no clinical significance and is therefore not abnormal. Emily had a sinus CT from 2005 that was negative. She's had some labs recently, including a blood count, a metabolic panel, which is looking at things like liver and kidney function as well as electrolytes, and a thyroid stimulating hormone, all of which were normal. So, for those of you who are out there, what sort of diagnosis does this presentation lead you to? And I'll give you a few minutes to think about it. Well, make that a few seconds. I'm going to move right along here, and so I will say that I'm going to diagnose Emily with migraine without aura after I really do my due diligence and make sure that I don't think she has a secondary or symptomatic headache. I think that would be pretty unlikely given her history. So this slide shows the International Classification of Headache Disorders, Volume 3, criteria for migraine without aura. And like I said, these criteria are really for scientific purposes, although they can be used for clinical purposes. But as you can see, they look a little cumbersome. So in the classification of headache disorders, migraine without aura is given this designation, 1.1, and it maps to an ICD-10 of G43.0. The criteria are as follows: a history of a pattern of 5 similar attacks fulfilling the following criteria. Timing is they last between 4 and 72 hours. Now, commentary regarding timing is that this assumes an untreated state. So, for example, if Emily takes ibuprofen and the headache is terminated in 2 hours, you can't really use that as the basis for the timing of her headache. The other thing is if Emily takes ibuprofen, falls asleep, and wakes up 8 o'clock in the morning the next day, her headache is assumed under these criteria to last until when she wakes up headache-free. So if she falls asleep after 2 hours, it's not a 2-hour headache, it's a 2-hour headache plus however long she was asleep for. Could be a 10-hour headache. The criteria also include at least 2 of the following features: unilaterality, in other words, on one side of the head, pulsating nature, moderate to severe severity, and aggravated by or causing avoidance of routine physical activity. Now, these criteria, my comments are that note that it says 2 of, right? The unilaterality of migraine is kind of overrated. I think it is true that people experience pain on one side of their head, but at some point in the migraine, it frequently becomes bilateral, so unilaterality is overrated. Pulsating quality is kind of nice to hear. It tends to be fairly specific for migraine, and the interesting thing about the pulsation of migraine is that they actually do not reflect the pulsation of the heart. They're much slower, but they are there and it's throbbing. Moderate to severe is quite important, and again, this assumes the untreated state. So if Emily is taking ibuprofen, which keeps her headache mild, although it still lasts throughout the day, and we're not even mentioning the impact of nausea, remember that that is an incorrect assumption, and we would have to assume the hypothetical state of what Emily would do or how she would feel if she had not taken a medication. The criteria number 4 in this case, aggravated by or causing avoidance of routine physical activity, that can often be asked or ascertained with one simple question, which is, under ideal circumstances, when you had your entire day to yourself, if you could do anything you wanted to do with your headache, would you go lie down in a dark, quiet room? And I think the answer for most people under those unrealistic situations is yes, of course they would. The reality is, though, is that most people answer the question not what would they do, but what do they do? And for most people who experience attacks of migraine with or without aura, they also have no excuse to not do their job, not go to school, not attend to their other tasks that they're required to do. And so many of those people will work through their pain and not, quote unquote, avoid routine physical activity. So it's very important in how you ask these screening questions. Criterion D requires at least one of the following: nausea and or vomiting, and photophobia and or phonophobia. And I will say that commentary regarding criterion 1 there, nausea and vomiting, that exists on a spectrum. And it's kind of easy to imagine the upper end of the vomiting spectrum, which usually looks like a toilet bowl. But what is the other end of the vomiting spectrum? I think it includes things like loss of appetite, followed by what we could call queasiness, followed by, mild nausea, followed by frank nausea, and then followed by the upper end of that. Photophobia and or phonophobia, I think, again, a lot of patients will tend to downplay those symptoms simply because they don't have the opportunity to seek out a dark, quiet environment. Many people are going to say that lights don't bother them or that sound doesn't bother them, but if you ask them what they could do under ideal circumstances, I think many people would say, I'd like to be in a room with the lights off and with nobody making any noise around me. All ICHD-3 diagnoses have this final catch-all caveat at the very end of a diagnosis, as depicted here in E, which says not better accounted for by another ICHD-3 diagnosis. And what that is there for is to remind us to always think about alternative diagnoses, particularly secondary or symptomatic headaches. and we'll get to those in a future video. So, what are the simple patterns to recognize in this case? Well, I think there's two of them. First of all, it's the fact that Emily presented to your clinic with a chief concern of headache. And there are excellent, well-grounded medical studies that show that when a patient is in a primary care waiting room to be evaluated for a chief concern of headache, there is a greater than 70% chance that the diagnosis will be migraine. The other pattern to recognize is the combination of disability, nausea, and light sensitivity. And this pattern is recognized in this formal tool called the ID Migraine Screener, which asks those three questions. Nausea? Does light bother you? Does your attack limit your ability to work? And if a patient answers affirmatively to two of those three questions, there is a sensitivity of 81% and a specificity of 75% for the diagnosis of migraine. Again, three simple questions. You pretty much have your diagnosis in hand, and you can get on with helping the patient. So how would we help this patient? I think that with every patient who you are assessing for headache, the first question is going to be, is this a primary headache disorder like migraine, or is this a secondary or symptomatic headache? In other words, a headache that is not just a headache. It is a headache that is a symptom of something else underlying. And once you've settled that, you can then think about the next series of questions, which is this a case that needs preventive treatment, and which acute treatment am I going to offer Emily? So let's consider whether Emily needs preventive treatment. And my list of considerations for whether someone needs preventive treatment is really 4 items long. Does Emily have 4 or more attacks per month? Are there disability or consequences associated with the headache? Is there an acute treatment failure? And is there analgesic overuse? And I think in Emily's case, she doesn't have more than 4 attacks a month. She's not overusing analgesic medications. But there's plenty of evidence to indicate that her employer is now creating consequences regarding missed work because of headache attacks. And I think also Emily has said that sometimes she can take appropriate over-the-counter treatment but still be in bed all day, and I would consider that to be an acute treatment failure. So I think by virtue of having both disability and consequences as well as acute treatment failures, I might consider or propose to Emily some sort of preventive approach. Now, preventive approaches can take the form of dietary regulation. They can take the form of nutraceutical approaches, but more often we consider pharmacologic therapies. And of course, there are really 4 platform drugs that can be used for most people for migraine prevention, and they include 2 drugs initially made for seizures. That's divalproex or valproic acid or Depakote, and the other seizure drug would be topiramate or Topamax, which also comes in various formulations and brand names. Then there's a blood pressure drug, propranolol, a beta blocker, and then there's a tricyclic antidepressant, which is amitriptyline or nortriptyline or protriptyline. But really, it's kind of easy to remember that there's 4 preventive options. And we'll get into appropriate choice of preventive treatments in a future video. Now, of course, Emily also needs acute treatment. And in her case, what I would think of doing would be to offer a highly effective therapy such as a triptan. Now, of course, the most highly effective therapy is injectable sumatriptan at a high dose, which would be 6 milligrams. Now, unfortunately, injectable sumatriptan is often poorly tolerated because what is powerful is often harsh. And so I might consider an oral triptan alternative instructed to be taken early at the onset of a headache. And early dosing actually potentiates the effects of a triptan by upwards of 30%. So early a patient takes a triptan early, they have a 30% more chance of coming out of that attack pain-free. To potentiate the effects of a triptan, I typically recommend that the patient take an NSAID in the form of naproxen 500 milligrams, as well as metoclopramide, which is an anti-nausea medication, 10 milligrams. And the combination of a triptan, such as rizatriptan, plus 500 milligrams of naproxen, plus metoclopramide, is actually a fairly potent migraine cocktail that tends to be minimally sedating and tends to be generally well tolerated. I also think that by treating early, by treating effectively, the chance that a headache goes over into the next day, the chance that a patient experiences 1 or 2 days of disability is lower, and that's very important. It could potentially forego the need for preventive treatment if that early aggressive treatment strategy were employed. The other reason, of course, to be treating migraines early and aggressively and effectively is one that I think we are all becoming increasingly aware of, which is that the more migraine attacks a person experiences, the more they are likely to experience more attacks. And eventually that can even become a serious problem called chronic migraine, where someone is experiencing headache attacks 15 or more days a month, of which 8 are migraine. And that is a devastating condition, not only to the person, not only to the person's health who is suffering it, but also it's financially devastating, and it has a huge societal impact. So early effective treatment of migraine is really a goal, and that should be a combination of acute treatments and the consideration of prevention treatments, even in patients where you think that prevention may be a little over the top. Usually it's not over the top. It's time to do it. I think by the time they're in your office, they are very likely to need consideration of a preventive treatment. So I wanted to thank everyone for your attention during this short video. Please give me a like. Please subscribe if you found this useful. And please see the pattern recognition playlist for more videos like this. I will include the list during some portion of this sign-out thing. So this has been Dr. Krob's Headache Vlog, and I'm Dr. Krob, Headache Expert. Thanks everyone for watching, and we'll see you in a future video.